Thank you. I'm very pleased and honored to be here today, and I will continue on the theme that Dr. Peterson started us down, and that is the role of rapid diagnostics in combating this crisis. Next slide. One more, please. So I'm here representing Alere today, and our corporate mission is to enable patients to take greater control of their own health under the direction and supervision of a healthcare provider. And what that means is we're all about the outcomes, the downstream consequences of this, meaning that we aim for earlier interventions, more targeted therapy, in the end, fewer hospitalizations, and trying to stem the increasing healthcare costs that our system faces. In the end, better outcomes. Next. So we're the world's leading provider of near-patient testing solutions for a whole range of areas, infectious disease being our largest focus. And what I mean by near-patient testing is that these tests can be sometimes done in the central laboratory setting, but they're designed and intended to be used closer to the patient. Now that may mean in the emergency department, it may mean in the ICU, or in your family doctor's office, and ultimately in the home. You see, we're based in Massachusetts, our global headquarters. We have significant presence in California, Maine, Georgia, New Jersey, Washington, Virginia, as well as Florida. And we have about 13,000 employees worldwide with representation in 100 countries. Next slide, please. So as we focus specifically on infectious disease, as I mentioned, we're the world's leading provider of rapid near-patient tests for infectious disease. And that spans a whole range of disease conditions, ranging from HIV to influenza and strep throat to malaria and dengue fever. We have a number of very simple, highly deployable rapid tests, but we've also launched and are launching new, innovative, transformational platforms for infectious disease testing. The first of which, shown on the top figure, is the Alere CD4 analyzer. This has been deployed in sub-Saharan Africa and will be coming to the United States shortly. The idea is to deliver lab-quality accuracy for CD4 testing for HIV-positive patients. And that value is very important in determining when to put the patient on antiretroviral therapy. The key that we brought to the table here was moving that testing from a central laboratory testing environment to the remote parts of the field in very challenging environments where the patients are located. So if we can do that in sub-Saharan Africa or Southeast Asia, we can certainly bring this to an HIV specialist office in Baltimore, for instance. Next, next image is the Alere Q analyzer. This is also a very compact, highly deployable molecular platform with focuses on HIV viral load for monitoring those patients with HIV, as well as high-burden diseases such as TB and hepatitis. And the last image is a product that's been developed and is launching later this year called the Alere I. And the idea is it is a molecular platform designed for the point of care specifically, so meant to be used outside of the laboratory. Next, please. So the previous speakers did a really excellent job in kind of laying the foundation and explaining the magnitude of this crisis that faces us today. Next. But this is perhaps one of my favorite images, and this, what you see, is the outcome of an independent think tank tasked with understanding what are the greatest threats to mankind. And you'll see my emphasis in that dark box is that increasing antibiotic resistance made it on the very short list, including things like nuclear proliferation and international terrorism. So this is real, it's here, and it's a real threat to mankind. Next, please. So this imagery, I think, is helpful in understanding what got us to this position and what we need to avoid, and that is the notion of using a bazooka to kill an ant. Right? The bazooka, in this case, is broad-spectrum antibiotics, and the ant is the bacteria or microorganism causing disease. We prefer, in the next slide, to take a more targeted approach where it's test, identify what it is that you're trying to treat it with a specific antibiotic of narrow focus, and then the patient does well without that collateral damage, that being the increasing antibiotic resistance. So next, please. And one more. As we think about Alere's products and how we plug into this antimicrobial stewardship issue, I view it sort of as a continuum of questions as we're engaging with the patients and as the clinicians are managing these patients. So we start at the top and note that each of the lighter pink boxes represents a near-patient test or rapid test that we have developed and we manufacture and sell. So you see somebody in the general practitioner's office who has a respiratory tract infection. The first question is, does this patient need antibiotics? Yes or no? And these various rapid tests can help make that decision along with the clinician's judgment. as you move further down the spectrum, then you say you have a bacterial infection, but which antibiotic will I use in this case? And we have tests for strep pneumo, which is the #1 cause of bacterial pneumonia. That's treated very differently than, say, Legionella, which is the cause of Legionnaire's disease. So by knowing what it is you're targeting, we can avoid the overuse of the bazooka and actually use a more targeted therapeutic. Finally, we have a test for MRSA, as we've heard about before, that helps with those patient management techniques. And then lastly, one thing I'd like to touch upon, because it's not truly a drug-resistant organism, but it's a downstream consequence of the overuse of antibiotics, is C. difficile, or C. diff, as you hear in the popular media. And what happens here is, I'm a healthy person, you're a healthy person, we have a number of different bacteria in our GI tract or our gut. And they're there to serve a purpose. They aid with digestion, they keep us healthy. But if you use the bazooka too much, right, you use the broad spectrum antibiotics, you kill the bad bacteria, but you also kill a lot of the good bacteria, and you can upset that balance in the GI tract. That allows C. diff, if it's present, to overgrow those healthy commensal organisms, and it can produce toxins which lead to very significant disease and ultimately potentially death. And we have tests for that to help manage those patients that are the sort of unfortunate recipients of the downstream consequences of indiscriminate antibiotic usage. Next, please. So I'm going to go through 2 examples of our tests and how they can be used. Next. Here, MRSA, we talked about the problem. I think you understand as a result of the previous speakers. The key here is that it's a problem, it's growing, right? And it's moving from the hospital setting to the outpatient or community setting. And it's at great cost. Next, please. So we have, Alere's developed a rapid MRSA test. The key here is instead of taking days for culture and traditional microbiology methods to give a result, we can give a result very quickly in only about 5 minutes. And we do so with excellent performance. So for those institutions that maybe don't have access to the molecular technologies we've talked about today, this is a very viable option. The key here is that it allows actionable information to be reported very quickly. And that's the key I think we've heard from Dr. Peterson and others, is that you need this information quickly, but then you must act on it. And so what do? It's a matter of continuing a patient who has MRSA identified on vancomycin, which is a fairly strong and last-ditch type of antibiotic, and then you put them into isolation so they don't spread it to others. Whereas if you determine they don't have MRSA, you can de-escalate, right, go from the bazooka to a more tailored weapon, and keep them out of isolation and avoid those costs. So there's operational efficiency and patient health outcome impacts here. Next, please. The last example I'll give is pneumonia. Next, please. So pneumonia is a major driver of healthcare spend, right? We've got 4 to 5 million cases per year. About half of those people become hospitalized. And when you combine pneumonia with influenza, it's a top 10 killer of Americans. Number 3 reason for discharge from the emergency department, and total economic impact of $17 billion a year. So this is significant. Next, please. We have a rapid pneumonia test. It gives results in only 15 minutes versus days potentially for the traditional microbiology-based methods or imaging like chest x-ray. The problem with chest x-ray is it may tell you have pneumonia, but it doesn't tell you what's causing pneumonia. And things like sputum culture and blood culture are lacking accuracy and take several days, whereas you need to treat this patient immediately. The key here with our test is that a positive result for strep pneumo, the #1 cause of pneumonia, it allows targeted therapy with penicillin rather than a broad-spectrum antibiotic. Next, please. And so this test, it's actually endorsed by the Infectious Disease Society of America and the American Thoracic Society in their guidelines for the diagnosis and management of community-acquired pneumonia as an effective tool to help manage these patients. The key, as I said here, we identify what's causing the disease, we treat strep pneumo and not the whole host of other things that might be causing pneumonia. And we've shown that we can reduce the length of hospitalization with a savings of $2,300 per day. Next, please. And I'll leave you with the last bit of insight here, and that is, next slide, our Test, Target, Treat campaign. We believe that fighting this is going to take an approach from different perspectives with public health and the medical societies as well as manufacturers. And we've started down the path earlier this year of our Test, Target, Treat campaign. So it's an educational campaign anchored by this Test, Target, Treat microsite. It's not a commercial platform, rather it's developed with a lot of content coming from the Alliance for the Prudent Use of Antibiotics. who I know couldn't be here today, but are one of the premier organizations in dealing with this crisis. And the idea is to provide neutral, education-rich content to educate healthcare providers. And ultimately, once we have some traction, we plan to go to the public as well with this. So that's what we're doing in terms of trying to educate the masses and move the needle when it comes to the overuse of antibiotics. Thank you.
Questions at the moment for our speaker? I guess I have one. Could you just elaborate a little more concretely on exactly what your test is doing and identifying specifically? Because I'm sure that the audience has a varying familiarity with the term molecular diagnostics, which we just kind of throw away. And I was kind of guilty of also just kind of throwing the term out there that maybe explaining a little more specifically. But I think especially in the context of the test you're just talking about, you could talk just a little more on a granular level about exactly how the test works.
Sure. So for the pneumonia product, we're not detecting the DNA or RNA, as the case may be for viruses. We're detecting actually part of the cell wall that makes up the bacterium, right? So we're not amplifying that. We're rather testing for part of the organism that's really indicative of that particular strain of bacterium. And in the case of MRSA, as we mentioned, that's Staph aureus that's resistant to a certain class of antibiotics. And it's resistant because it has a different feature of its cell wall. And we detect that modified or adulterated protein on the surface of the bacterium as a proxy for resistance to methicillin.